Good afternoon, everyone, and today's topic is antiviral drugs. And antiviral drugs are, uh, are required for the treatment of uh, virus diseases, including influenza virus, uh, hepatitis, and HIV. So these are three main diseases that require antiviral drugs. And the viruses are quite different from the bacteria because they lack both a cell wall and a cell membrane, and they don't carry out metabolic processes. And viruses use much of the host's metabolic processes, and that is why there are only few drugs that are selective enough to prevent viral replication without injury to the host cells. Therapy for viral diseases is further complicated by the fact that the clinical symptoms appear late in the course of the disease, at the time when most of the virus particles have replicated. At this stage of viral infection, administration of drugs that block viral replication almost ineffective. However, some antiviral agents are useful as prophylactic agents, and the few groups that respond to available antiviral drugs are discussed further. Uh, the, they usually are grouped by the type of the viral infection they are effective for. And most common viral infections are respiratory viral infections, and they include influenza A and B and syncytial virus, or more specifically respiratory syncytial virus, or RSV. Uh, and the first and most effective group for the treatment of the influenza virus are neuraminidase inhibitors. The neuraminidase inhibitors include oseltamivir and zanamivir, and they are effective both against type A and type B influenza. They don't interfere with the immune response to influenza vaccine, and when administered prior to exposure, uh, neuraminidase inhibitors prevent infection, and when administered within 24 to up to 48 hours after the onset of symptoms, they modestly decrease the intensity and duration of them. The mechanism of action employ a specific neuraminidase that is inserted into the host cell membrane for the purpose of releasing newly formed variants. This enzyme is essential for the virus life cycle, and oseltamivir and zanamivir selectively inhibit the neuraminidase, thereby preventing the release of new virions and their spread from cell to cell. Oseltamivir is orally active prodrug that is rapidly hydrolyzed by the liver to its active form, Zanamivir is not active orally and is administered via inhalation. Both drugs are eliminated and unchanged in the urine. The most common adverse effects of oseltamivir are gastrointestinal discomfort and nausea, which can be alleviated by taking the drug with food. Irritation of the respiratory tract occurs with zanamivir. It should be used with caution in individuals with asthma or chronic obstructive pulmonary disease, because bronchospasm may occur. Mutations of the neuraminidase enzyme have been identified in adults treated with either of the neuraminidase inhibitors. Thus, uh, mutants, however, are often less effective and virulent than the wild type. The second group is less effective, and the therapeutic spectrum of the adamantane derivatives amantadine and trimetadine is limited to influenza A infections. Due to widespread resistance, the adamantanes are not recommended for the treatment or prophylaxis of influenza A. The mechanism of action of adamantine and trimetadine uh, interfere with the function of the viral M2 protein, possibly blocking uncoating of the virus particle and preventing viral release within infected cells. Both drugs are well absorbed after oral administration. Adamantine distributes throughout the body and readily penetrates into the central nervous system, whereas trimetadine does not cross the blood-brain barrier to the same extent. Amantadine is primarily excreted unchanged in the urine, and dosage reduction are needed in renal dysfunction. Trimetadine is extensively metabolized by the liver, and both the metabolites and the parent drug are eliminated by the kidney. Amantadine is mainly associated with central nervous system adverse effects such as insomnia, dizziness, and ataxia. More serious adverse effects may include hallucinations and seizures. Amantadine should be employed cautiously in patients with psychiatric problems, cerebral atherosclerosis, renal impairment, or epilepsy. Trimetadine causes fewer central nervous system reactions. Both drugs cause GI intolerance. They should be used with caution in pregnant and nursing mothers. Resistance can develop rapidly, and resistant strains can be readily transmitted to close contacts. Resistance has been shown to result from a change in one amino acid of the M2 matrix protein. Cross-resistance occurs between the two drugs. Ribavirin, a synthetic guanosine analog, uh, is effective against a broad spectrum of RNA and DNA viruses. For example, ribavirin is used in treating immunosuppressed infants and young children with severe RSV infections. Ribavirin is also effective in chronic hepatitis C infections when used in combination with interferon alpha. Ribavirin inhibits replication of RNA and DNA viruses. The drug is first phosphorylated to the 5-phosphate derivatives, and the major product being the compound ribavirin triphosphate, which exerts as its antiviral action by inhibiting guanosine 3-phosphate formation, preventing viral messenger RNA capping, and blocking RNA-dependent RNA polymerase. Ribavirin is effective orally and by inhalation. An aerosol is used in the treatment of RSV infection. Absorption is increased if the drug is taken with a fatty meal. The drug and its metabolites are eliminated in urine. Side effects of ribavirin include dose-dependent transient anemia. Elevated bilirubin has also been reported. The aerosol may be safer, although respiratory function in infants can deteriorate quickly after initiation of aerosol treatment. Therefore, monitoring is essential. Ribavirin is contraindicated in pregnancy. So the next disease that we discuss today is the hepatitis, and it, hepatitis viruses uh, have a pathogenesis specifically involving replication in and destruction of hepatitis uh, and hepatitis B, that is DNA virus, and hepatitis C, that is RNA virus, are the most common causes of chronic hepatitis, as cirrhosis and hepatocellular carcinoma, and are the only hepatic viral infections for which therapy is currently available. So there is no therapy for hepatitis A, D, and E. And hepatitis A is a commonly encountered infection caused by oral ingestion of the virus, but it is not a chronic disease. Chronic hepatitis B may be treated with peg interferon alpha 2A, which is injected subcutaneously once weekly. The interferon alpha 2B injected intramuscularly or subcutaneously 3 times weekly is also useful in the treatment of hepatitis B, but peg interferon alpha 2A has a similar or slightly better efficacy with improved tolerability. Oral therapy for chronic hepatitis B includes lamivudine, adefovir, entecavir, tenofovir, and telbivudine. The preferred treatment for chronic hepatitis C is the combination of peginterferon alpha 2A or peginterferon alpha 2B plus ribavirin, which is more effective than the combination of standard interferons and ribavirin. For genotype 1 chronic hepatitis C virus or HCV and NS3-4A protease inhibitors such as boceprevir and delaprevir should be added to pegylated interferon and ribavirin. Interferons are a family of naturally occurring inductible glycoproteins that interfere with the ability of viruses to infect cells. The interferons are synthesized by recombinant DNA technology, and at least 3 types of interferons exist: alpha, beta, and gamma. One of the 15 interferon alpha glycoprotein, interferon alpha 2B, has been approved for the treatment of hepatitis B and C, condyloma acuminata, and cancers such as hairy cell leukemia and Kaposi sarcoma. In pegylated formulations, bis-monooxypolyethylene glycol has been covalently attached to either interferon alpha 2A or alpha 2B to increase the size of the molecule. The larger molecular size delays absorption from the injection site, lengthens the duration of action of the drug, and also decreases its clearance. The antiviral mechanism is incompletely understood. It appears to involve the induction of host cell enzymes that inhibit viral DNA translation, ultimately leading to the degradation of viral uh, mRNA and tRNA. The uh, interferon is not active orally, but it may be administered intralesionally, subcutaneously, and intravenously. Very little active compound is found in the plasma, and its presence is not correlated with clinical responses. Cellular uptake and metabolism by the liver and kidney account for the disappearance of interferon from the plasma. Negligible renal elimination occurs. Adverse effects include flu-like symptoms such as fever, chills, myalgias, arthralgias, and GI disturbances. Fatigue and mental depression are common. These symptoms subside with continued administration. The principal dose-limiting toxicities are bone marrow suppression, severe fatigue, and weight loss. Neurotoxicity, characterized by somnolence and behavioral disturbances, autoimmune disorders such as thyroid, and rarely cardiovascular problems such as heart failure. Interferon may also potentiate immunosuppression caused by other bone marrow suppressive agents. The second drug is lamivudine. Lamivudine uh, is a cytosine analog is and inhibits both hepatitis B virus and human immunodeficiency virus reverse transcriptases. Lamivudine must be phosphorylated by host cellular enzymes to the triphosphate, that is, active form. This compound completely inhibits HBV RNA-dependent DNA polymerase. As with many nucleotide analogues, the intracellular half-life of the triphosphate is many hours longer than its plasma half-life. The rate of resistance is high following long-term therapy with lamivudine. Lamivudine is well absorbed orally and is widely distributed. It is mainly excreted unchanged in urine. Dose reductions are necessary when there is moderate renal insufficiency. Lamivudine is well tolerated with rare occurrences of headache and dizziness. The third drug is adefovir. Adefovir is a nucleotide analog that is phosphorylated by cellular kinases and to adefovir diphosphate, which is then incorporated into viral DNA. This leads to termination of chain elongation and prevents replication of HBV. Adefovir is administered once a day and is renally excreted via glomerular filtration and tubular secretion. As with other agents, discontinuation of adefovir may result in severe exacerbation of hepatitis. Nephrotoxicity may occur with chronic use, and the drug should be used cautiously in patients with existing renal dysfunction. Adefovir may raise levels of tenofovir through competition for tubular secretion, and concurrent use should be avoided. The fourth drug is the same entecavir. Entecavir is a guanosine nucleoside analog for the treatment of HBV infections. Following intracellular phosphorylation to the triphosphate, it competes with the natural substrate deoxyguanosine triphosphate for viral reverse transcriptase. Entecavir is effective against lamivudine-resistant strains of HBV and is dosed once daily. The drug is primarily excreted unchanged in the urine, and dosage adjustments are needed in renal dysfunction. Concomitant use of drugs with renal toxicity should be avoided. Telbivudine, so another voodoo drug, is a timidine analog that can be used in the treatment of HBV. Telbivudine is phosphorylated intracellularly to the triphosphate, which can either compete with endogenous timidine triphosphate for incorporation into DNA or be incorporated into viral DNA, where it serves to terminate further elongation of the DNA chain. The drug is administered orally once a day. Telbivudine is eliminated by glomerular filtration as the unchanged drug. The dose must be adjusted in renal failure. Adverse reactions include fatigue, headache, diarrhea, and elevations in liver enzymes and creatine kinase. Next two drugs are boceprevir and tenofovir. These are the first oral direct-acting antiviral agent for the adjunctive treatment of chronic HCV genotype 1. These HCV and S3-4A serine protease inhibitors covalently and reversibly bind to the NS3 protease active site, thus inhibiting viral replication in host cells. Both drugs are protein inhibitors of viral replication, however, they have a low barrier to resistance and when used as monotherapy, resistance quickly develops. Therefore, boceprevir and tenofovir should be used in combination with PEG interferon alpha and ribavirin in order to improve response rates and reduce the emergence of viral resistance. Boceprevir is administered with food to improve absorption. The absorption of tenofovir is enhanced when it is administered with non-low-fat food. The metabolism of boceprevir and tenofovir occurs with CYP450 isoenzymes because both drugs are strong inhibitors of CYP3A4/5 and are also particularly metabolized by this enzyme. They have the potential for complex drug interactions. Common adverse events with boceprevir include anemia and dysgeusia. Tenofovir is associated with rash, anemia, and anorectal discomfort. So the next disease is the herpes virus infection. The herpes viruses are associated with a broad spectrum of diseases, for example, cold sores, viral encephalitis, and genital infections. The drugs that are effective against these viruses exert their action during the acute phase of viral infections and are without effect during the latent phase. The first and most commonly used drug is acyclovir. That is actually acylglucosamine, is the prototypic anti-herpetic therapeutic agent. Herpes simplex virus, types 1 and 2, varicella zoster virus, and some Epstein-Barr virus mediated infections are sensitive to acyclovir. It is the treatment of choice in HCV encephalitis. The most common use of acyclovir is in therapy for genital herpes infections. It is also given prophylactically to seropositive patients before bone marrow transplant and post-heart transplant to protect such individuals from herpetic infections. Mechanism of action includes of the uh, the phosphorylation in the cell by herpes virus encoded enzyme thymidine kinase. Therefore, virus-infected cells are more susceptible. The monophosphate analog is converted to the D-3-phosphate formed by the host cell kinases. Acyclovir 3-phosphate competes with deoxyguanosine 3-phosphate as a substrate for viral DNA polymerase and is itself incorporated into the viral DNA, causing premature DNA chain termination. Acyclovir is administered by intravenous, oral, or topical routes. The efficacy of topical application is questionable. The drug distributes well throughout the body, including the cerebrospinal fluid. Acyclovir is partially metabolized to an inactive product. Accretion into the urine occurs both by glomerular filtration and tubular secretion. Acyclovir accumulates in patients with renal failure. The value ester val acyclovir has greater oral bioavailability than acyclovir. This ester is rapidly hydrolyzed to acyclovir and achieves levels of the latter comparable to those of acyclovir following intravenous administration. Side effects of acyclovir treatment depend on the route of administration. The example it may include local irritation from topical application, headache, diarrhea, nausea, and vomiting after oral administration. Transient renal dysfunction may occur at high doses or in a dehydrated patient receiving the drug intravenously. Cidofovir is approved for the treatment of cytomegalovirus, CMV, rhinitis, and patients with AIDS. Cidofovir is a nucleoside analog of cytosine, the phosphorylation of which is not dependent on viral or cellular enzymes. It depends on inhibition of viral DNA synthesis. Slow elimination of the active intracellular metabolite permits prolonged dosage intervals and eliminates the permanent venous access needed for ganciclovir therapy. Cidofovir is administered intravenously. Intravitreal injection, that is injection into the vitreous humor between the lens and the retina of cidofovir is associated with risk of hypotony and uveitis and is reserved for extraordinary cause cases. Cidofovir produces significant renal toxicity, and it is contraindicated in patients with pre-existing renal impairment and in those taking nephrotoxic drugs. Neutropenia and metabolic acidosis also occur. Oral probenecid and IV normal saline are administered with the cidofovir to reduce the risk of nephrotoxicity. Since the introduction of highly active antiretroviral therapy, that is HAART, the prevalence of cytomegalovirus infections in immunocompromised hosts has markedly declined. as has the importance of cidofovir in the treatment of these patients. Foscarnet, unlike the antiviral agents, is not a purine or pyrimidine analog. Instead, it is a phosphonoformate, so and does not require activation by viral or cellular kinases. Foscarnet is approved for CMV retinitis in immunocompromised hosts and for acyclovir-resistant HCV infections. Foscarnet works by reversibly inhibiting viral DNA and RNA polymerases, thereby interfering with viral DNA and RNA synthesis. Mutation of the polymerase structure is responsible for resistant viruses. Foscarnet is poorly absorbed orally and must be injected intravenously. It must also be given frequently to avoid relapse when plasma levels fall. It is dispersed throughout the body, and greater than 10% enters the bone matrix, from which it slowly leaves. The parent drug is eliminated by glomerular filtration and tubular secretion. Adverse effects include nephrotoxicity, anemia, nausea, and fever. Due to chelation with different cations, hypocalcemia and hypomagnesemia are also seen. In addition, hypokalemia and uh, hyperphosphatemia, seizures, and arrhythmias have been reported. Ganciclovir is an analog of acyclovir that has greater activity against cytomegalovirus. It is used for the treatment of cytomegalovirus retinitis and immunocompromised patients and for CMV prophylaxis in transplant patients. Like acyclovir, ganciclovir is activated through conversion to the nucleotide triphosphate by viral and cellular enzymes. The nucleotide inhibits viral DNA polymerase and can be incorporated into the DNA, resulting in chain termination. Ganciclovir is administered IV and distributed throughout the body, including the uh, uh, cerebrospinal fluid. Excretion into the urine occurs through glomerular filtration and tubular secretion. Like acyclovir, ganciclovir